Next, we come to this end of this prostate cancer session. We'll come to the question and answer session. First question is to Dr. Mohan Keshamurthy and Dr. Kunal. Does Dr. Transperineal approach to biopsy has added advantage over transrectal biopsy in targeting lesion? Dr. Mohan.
That's a very interesting question. We are on an advanced BK ultrasound platform to do biopsies. One of the reasons why transperineal biopsy has not become popular at this point in time is the lack of a probe. But on the BK with a perineal probe, possibly it is the way forward as we go along. There are two other interesting aspects. If you do transperineal biopsy, it will help the radiation oncologist to plan brachytherapy. That is one. The other interesting part would be possibly it will make the procedure itself more palatable to many patients, especially those who can't be given a lithotomy position or a left lateral position. Possibly the perineal biopsy would be the easiest way to go along. Now, as far as the efficacy or the utility of the biopsy, I would let Dr. Kunal answer this question.
Thank you, sir. So I believe there have been many studies over the diagnostic advantage of one approach over the other, but there hasn't been any significant diagnostic advantage of transperineal biopsies. There have been a slight, a better advantage in terms of diagnosing diseases which involve the anterior and the apical segments through the transperineal route. Also, biopsies which are transrectal, they tend to be understaged more than a transperineal biopsy. So that has, transperineal biopsies have an added advantage over that. Also, I believe the major advantage comes by the fact that there is far lesser, incidences of sepsis in transperineal biopsies than transrectal biopsies. So I believe those are the areas where, a transperineal biopsy scores over transrectal biopsies. Thank you.
One more question to Dr. Kunal. What is significant tumor in a biopsy?
Clinically significant tumor in prostatic core biopsies is any tumor which has Gleason's of greater than or equal to 4 and which involves at least 3 mm of the prostatic core tissue or 0.5 cc by volume in terms of prostatectomy specimens.
Thank you, Dr. Kunal, for the answer. Next question is to Dr. Mohan. How do you identify the right plane in nerve sparing robotic radical prostatectomy, and what approach you use, anterior or posterior in radical prostate in robotic?
I will take the first question first. We identifying the nerve sparing portion of the procedure is one of experience. We are fortunate to have as my colleague, Dr. Sriharsha Harinatha, who had a stint in Florida, made the learning curve easier. If the tumor is high grade, then on the side the primary tumor is located, I wouldn't do a nerve sparing at all. We will restrict it to the other side. In a low grade tumor, we would possibly go ahead sparing nerves on both sides. Again, if it is a high grade tumor, we will go intrafacial between the levitani and the prostatic capsule. If it is low grade, we go interfacial. So 2 and 11 o'clock are the sites to look for the neurovascular bundle to release it off the capsule so as to preserve them. Again, the technique is dictated by experience and has a steep learning curve, but the benefit outweigh the learning curve in the sense that a younger patient with the intermediate Gleason would hugely benefit with potency retained at 6 months with no medication or some medication. The second part, you can do both anterior and posterior as a group at Fortis Hospital's Banagata Road. Many of us, about 7 of us, do robotic radical prostate, Dr. Sriharsha being the lead. All of us do the posterior approach. It makes learning easy. It makes comparison easy. And that's the reason we do. I wouldn't put one approach over the other, but at our center, a posterior approach is the one we follow.
Thank you, sir. One next question is there a age limit to suggest RRP confined cancer prostate?
This is an interesting question. Again, age is a number. I would look at not at the chronological age, but the biological age of the patient. It's very important to understand that if the patient has another 10 years of active life, good on the Karnofsky scale, I would go ahead and provide a robotic radical prostatectomy as long as the counseling is done of the other options available for the patient. Intention to cure would be a radical prostatectomy and radical radiotherapy. And intention to control would obviously be hormonal manipulation initially. So the question is very simple. It has to be individualized to a given patient. Counseling has to be done. Alternative treatment has to be explained. And then if the patient has adequate life expectancy and the patient is willing, I think robotic radical prostatectomy, being a surgeon, would be the right way, in my perspective, to go forward.
Thank you, sir. Next question is to Dr. Madhusudan. When would you suggest SBRT in cancer prostate? What are the logistics and the cost involved?
Thank you for the question, sir. SBRT, also called stereotactic body radiotherapy, is an extreme form of radiation therapy, extreme form of ultra radiation therapy, wherein compared to conventional radiation, where we give the conventional radiation therapy to the prostate over a period of 7 to 8 weeks, here we can complete the same radiation therapy in about 3 or 5 sessions itself. So this is possible with the use of present day imaging, especially with the refinement of the MRI and the PET CT scan. They use the PET CT and MRI based contouring and planning methods to localize the prostate, and also with the present high-end treatment techniques. The cost for the stereotactic body radiation therapy, the package includes around 3.3 lakhs.
Thank you, Dr. Madhusudan.
Thank you.
The last question is to Dr. Gayana. Is there a role for upfront lutetium therapy in CA prostate? And if it is so, what is the cost and the logistics which are involved?
There are a few trials which are running for upfront lutetium therapy along with enzalutamide, and one of the trial was discontinued because of the side effects. So as of now, lutetium or actinium therapy is only considered in the end of the road treatment. And coming to what is the cost, we have two types of lutetiums. That is, we can procure lutetium either indigenous, that is produced by Brit Mumbai. So Brit Mumbai lutetium based treatment would cost 1.8 to 2 lakh per cycle for a patient. And if we are importing lutetium, then it would cost 2.5 to 3 lakh per cycle per patient based on the dose. And then we give around 4 doses to each patient spaced at 2 months interval. Thank you.
Thank you, Dr. Gayana.